I am Karen Paulson-Edwards, Advisor, Climate Change and Environmental Determinants of Health with the Pan American Health Organization based here in Barbados. On behalf of the PAHO Regional Program of Entomology in Public Health and Vector Control, I would like to welcome you to this session titled Risk Stratification as a Tool to Guide Aedes aegypti Control Interventions in Urban Areas. Now, in this new COVID era, the additional stresses on health systems and the public health measures which we must adopt to slow or to stop the epidemic have affected entomological surveillance and vector control activities. However, it is essential that Aedes aegypti control activities continue, but we have to make adjustments to how we operate. As your host, it gives me great pleasure to welcome and to introduce to you our presenter for today, Dr. Gonzalo Vasquez Procopec, Associate Professor in the Department of Environmental Sciences at Emory University. Dr. Vasquez Procopec's primary research areas are disease ecology, spatial epidemiology, and global health. His research and mentoring programs focus on three central topics. One, identify the major determinants of the transmission and geographic propagation of vector-borne diseases of global health significance. Two, study the ecology of the insect vectors and reservoir hosts and the role of human and vector behavior in pathogen transmission dynamics. And three, use an evidence-based approach to identify targets that can help improve public health policy and practice. Over the past 15 years, Dr. Vasquez Procopec has been involved in diverse research projects studying the ecoepidemiology of vector-borne and parasitic diseases, primarily dengue, Chagas disease, and West Nile virus. As a result, he has published more than 100 peer-reviewed articles and regularly participates in scientific panels for the National Science Foundation, the National Institutes of Health, the Centers for Disease Control and Prevention, and the World Health Organization as an expert in vector ecology and control. Dr. Vasquez Procopec, welcome, and over to you.
Thank you very much, Karen, and it's a true pleasure to be, part of this very exciting series of webinars. Let me get situated here. And in a way, before I get started, probably I'd like to provide some overview of the importance of this topic, right? And I think, as a scientist, one can say that, we like to generate data and knowledge and advance the frontiers of knowledge. But I think there's a really unique partnership and the leadership of PAHO in this venture has been great in that we're trying to use this knowledge that is being generated about Aedes aegypti ecology and dengue epidemiology to try to inform vector control and public health policy. So today, in a way, I'm going to talk to you about one of the tools that we've been developing over the years and now is becoming a very useful approach to understand how to design surveillance and control activities to control a vector that is quite difficult to control. And I'm talking about Aedes aegypti. The reason why is because this mosquito, as simple and small as you know it, it's really well adapted for not only surviving very different environments and different conditions in urban areas, but also it has been adapted to transmit very efficiently many pathogens that we all know. And that reason of high efficiency is driven by specific traits that make it a very important and difficult to control species. And one of them is it only feeds on humans, right? So if we have in a house many other reservoirs, humans are the ones that it prefers with high proportion. And what tends to happen is not only feeds on humans, but compared to other mosquitoes very often, every day and a half, for instance. And when we join that with the ability that these mosquitoes have to lay eggs in multiple small containers and the very quick population turnover that they have, we actually have a species that not only adapted to our current environment, but is constantly evolving to adapt to the new conditions that we put on them. And in a way, it's a very big challenge. So anybody would say, well, it's just killing a mosquito and controlling disease. Well, we've been trying that for a long time. And before we go into the difficulties, I would say that although we're having trouble controlling and containing transmission, we also have a very good example of successful stories in the control of Aedes aegypti. And all that was based on a very clear mission and goal, which was the eradication of the species, given its role as a vector of yellow fever, and particularly urban yellow fever in the early 1930s and beyond. And in a way, what the work done in the Americas primarily, trying to eradicate and accomplishing that for quite a long time, Aedes aegypti, it shows that if we actually do vector control expeditiously, we thoroughly control the vector, we can have a success in containing. So some people, when they talk about vector control doesn't work, we really have strong evidence that it does. The problem is, how can we achieve that in the current context, in that after the 1970s, basically the species colonized or recolonized the Americas, as well as many other parts of the world. And it's continued expanding in many ways. So there are multiple factors that actually have influenced this recolonization. We can go in great detail, but one of them is the main thread that connects everything, which is unprecedented urbanization. From the 1970s till the present, we have seen a very rapid and in many ways disorganized urbanization, urban growth. At present, more than 80% of the population in Latin America lives in urban areas. And associated with that and other factors that I can list here, we see that the problem of Aedes recolonization, it wasn't just that vector control was dismantled in terms of the yellow fever infrastructure, but other conditions really start adding up, like how water supply occurs in these urban areas, particularly large and urban slums and other conditions, as well as how humans have moved the virus and the mosquitoes at different geographies. So the bottom line is, when we add all these determinants, we find that Aedes aegypti not only is populating most of the Americas and expanding into northern and southern latitudes, but also in addition to Aedes aegypti, now we have a more complicated condition than before, which is multiple viruses transmitted in some areas even simultaneously. So this new reality, in a way, not only is more challenging than before, but in a way allow us to make a different way of thinking the problem, which is how can we use the knowledge that we have and we have gathered over the last 50 years to try to improve the way that vector control and surveillance are done. And at the core of what we need to revisit is this idea that what was the main driver of eradication of Aedes aegypti in the 1950s, which was homogeneous and effective large-scale coverage of vector control. There's a really very important article that I recommend everyone to take a look and read, led by Olaf Horstig, where basically they did a very thorough assessment of what are the, in a way, deficiencies and strengths of vector control services. And as they very clearly state, there's a basically limitation on multiple dimensions, not only in the human and financial resources, but also in the ability that with those resources programs have to reach a geographical coverage that is sustainable and effective in a way. Coupled with this very important article, there is another one that in a way lays the ground of the current situation we have, in that when researchers evaluate the efficacy of different vector control approaches, like spraying, we actually can see that for most of them, we may be applying them in ways that might not be having the impact that we desire. And that comes from the idea that, for instance, if we apply outdoor insecticides and the mosquitoes resting indoors, we might be applying something that works, but in some situations might not be as effective. So for that, there is a renewed perspective in that we really need to understand much better what methods of the currently available we have, how do they work, where do they work, and in what conditions they might not actually be that effective. And that in a way is at the backbone of really redesigning what we call integrated vector management, right? But coverage tends to suffer, and the application of methods tend to suffer. This is a photo shared by a good colleague of mine, and in the wake of the Zika virus pandemic, people in New Delhi, thermal fogging in a stadium just because of the potential threat, which wasn't that big at that place, of a Zika outbreak. So there's a method that works, maybe the application doesn't. So if we tie now the current knowledge of Aedes-borne virus epidemiology, we can actually see why some of these methods might not be that effective. It's not only that we might be not applying them in the context where they are effective. And the main two pieces of work that we've been doing over the last 10 years that are really important is basically how asymptomatic carriers might be transmitting the virus, and also how mobility of people might be fueling these outbreaks in small as well as large extents. And what happens with asymptomatics, it drills down to one article done by some colleagues where they actually found people in hospitals that had dengue, and then they went to their houses to look for what we call contacts, individuals in the house that either had dengue or potentially were asymptomatic. They didn't have any symptoms that were associated with any illness whatsoever. And what they did with these people was get lab mosquitoes, about 10 of them, and put them on their arm and just feed mosquitoes and look at the infection in the mosquitoes to see if individuals with symptoms or without symptoms were able to be infectious, right? So we're able to get these mosquitoes PCR positive for dengue virus. And what they found was really striking. They actually found that if we look at this red, these are people who are asymptomatic, no symptoms to dengue whatsoever. And what they saw is that starting at 4 logs of virus, they rapidly become infectious. That means that the percentage of mosquitoes they infect goes very rapidly from 0 all the way to 100%. And at very moderate, in a way, levels of viremia, they're actually more infectious. They become more rapidly infectious than people with symptoms. So what this study in a way shows is those individuals who are asymptomatic carriers do contribute to the infection of mosquitoes. And some work that we did with colleagues from University of Notre Dame and other institutions use this data to, in a way, plug and play, look at a mathematical model of transmission and try to ask the question, well, individually, these people might be infected mosquitoes. At the population level, what their contribution to transmission may be. And our findings are quite significant, because we predicted that because asymptomatic carriers could be up to 10 times more the number of symptomatic individuals, they might be responsible for about 80% of all the dengue infections that we see in the system, not necessarily symptomatic infections, but all the infections. So in a way, if we actually look at asymptomatics, we can think of them as the tip of an iceberg that is really driven primarily by those individuals with mild infection, with mild symptoms or no symptoms at all. And in a way, it's something very similar now to you, because the coronavirus pandemic is really drilling down to the same issue, which is asymptomatic carriers transmitting the virus. So the other component that's really key for really revisiting control approaches is mobility of humans. And as I showed on the first slide, Aedes aegypti is primarily a day-biting mosquito, so transmission it not necessarily occurs where people sleep, but it might be occurring where they go during their daily lives. And we've done extensive work describing that in different levels, but I always say that one image is more important than 1,000 words. So I'm going to show you some results from this article, in which we actually use GPS data loggers, and we had people, about 600 participants from the city of Iquitos in the Peruvian Amazon, wear them for about 2 weeks. And these GPS loggers only collected information during the daytime at a 2.5 minute interval. So the idea is people were wearing them all the time, and we downloaded the data, everything was anonymous. And when we actually look at their mobility patterns, what we see in this image is black indicates where those individuals lived. We actually collect the data from these 2 neighborhoods, and yellow indicates where they moved within a 2-week period. As you can see, if you're the head of vector control for Iquitos, you might wonder, everywhere in the city is an area of transmission. So the challenge now for vector control really is, how can we respond to transmission if one, people are asymptomatic and we cannot detect them, and two, people are moving beyond their house and their residence, which is the unit where response very often is done, might not be representative of the place where the virus is moving next. Just going, briefly showing, similar data now from another setting, from Cairns in Australia. This article that we did basically worked something different than in Iquitos, because we not only have a city, which is Cairns, but also included satellite towns. And this is typical of any metropolitan area where we have a city that works as a hub, and people live in towns and might be related to the city because they work, they go for visiting family or friends or leisure, right? And we had contact tracing, something that now it's very familiar to you. So in Cairns, there are nurses that every symptomatic case of dengue, they do a phone interview where they ask very simple questions of where they've been the last 2 weeks. And when we integrate the data, in a way, these dots indicate each one of these satellite towns. This is the city of Cairns. What we see in this diagram with arrows is people residing in this town. There's a thick arrow going into the city. That means that a high proportion of residents from this town are going during the daytime to spend some time in Cairns. And as we can see, there is what we call a hub dynamic here, in which basically Cairns is really attracting people from all these towns that are farther away. We did analysis because we have contact tracing data. So we did analysis and we look at dengue cases on all these network. And we actually were able to identify that people from many of these satellite towns didn't lead to any secondary cases in their town, but they actually were exposed and infected in the city of Cairns. And that's shown in this figure. And then now the arrows indicate the proportion of cases that had a putative infectious or transmission location in any of the other towns. And as you can see for this town, Palm Cove, none of the cases that were reported in Palm Cove were associated with transmission locally. All of them were associated with transmission in Cairns. So this brings to another issue, which is maybe when you send a team and respond to cases in this area, you are missing the point that a lot of the transmission might be accumulated in what we call hotspots or areas of high transmission risk. So if now we are responding to cases, which is what most countries do, we actually might find some limitations in how to prevent outbreaks in areas that are highly endemic. So in a way, the question that we've been asking over the last few years is, what's best, to prevent, to react, or to do both, right? And again, we because it's difficult to get this data, we were able to assess some of these with some mathematical models and simulations. And basically what we did here is simulating control in the city of Iquitos, the one that I showed you before, assuming control for the whole city, but with different strategies, right? One is doing nothing, and that's our null approach. And the other one is do something that is done in many cities, which is when you have a reported symptomatic case, you do intra-domiciliary ULV spraying, in this case with a pyrethroid or malathion, depending on the city. And the alternative to that was do some preventive control that involved the application of residual insecticides through an approach called targeted indoor residual spraying. And data, I'll show you this in next slide, it shows that it could be an average about 4 months effective. So we have a time window of control that would make these preventive and these a reactive approach. So we simulated transmission in Iquitos, and we found that compared to doing nothing, ULV had a number of infections that were predicted, a reduction in number of infections. So being reactive had an effect. It was important for us, was about a 52% reduction compared to doing nothing. But doing these TIRS had an effect that led to about 94% reduction in cases. So it seems that there is some value in doing reactive control, but if you layer preventive application, which happens before cases occur, you might actually get some additional efficacy into the system. Just for those of you who might be wondering what targeted indoor residual spraying, and I'm sure that there's going to be another webinar about that in the future, the Pan American Health Organization has published this manual where the method is described in detail. And the idea, this is not malaria IRS. This is a method that has used the behavior and ecology of Aedes aegypti to really focus where residual insecticides should be applied. How it works is basically, if you look at This line, this is mortality inside a house of mosquitoes. This will be doing the malaria type IRS, in which you move all the furniture and you spray from top of the walls to the bottom and ceiling, and you don't leave anything treated. And basically targeted indoor residual spraying would be just spraying half the wall, because we know aegypti rests in the lower part, and also not necessarily moving all the furniture and that, just really trying to coat, the areas where we know Aedes aegypti rests, and not having to do a lot of the work prep that leads to, hours sometimes of labor per individual house. And what we see is there's no significant difference when we use bendiocarb, for instance, between doing this labor-intensive indoor residual spraying and doing the targeted IRS, right? So then it's feasible if we want to do something like this in terms of the time it takes. And some data that we collected from Australia, where this was done after an outbreak, during an outbreak, shows that if you do this IRS in houses that were treated, the proportion of cases that were detected were about 5%, versus in areas that were not treated, the proportion of cases keep climbing up, right? If we calculate and measure out the difference between these two, we say that IRS had an average of 86% reduction compared to doing nothing. And which is in part to what the model predictions in the previous slide show. So in a way, there's an approach for doing preventive control. There's an approach of integrating reactive and preventive control, which brings me to this core, in a way, slide for me, which is the way we've been doing surveillance and control, which is chasing cases and in a way utilizing a lot of the tools that were designed for the yellow fever eradication approach, might have some limitations with the current understanding of how human mobility, the immunity to different viruses, not only dengue, as well as the variable distribution of Aedes aegypti. So maybe entomological information alone is not sufficient to make predictions in real time of where transmission may happen. And this idea of paradigm shift comes from this notion that, as I told you, there's heterogeneity. Some areas might have more transmission than others. So instead of trying to cover everything and do as it was done in the 30s, maybe we have to be a bit more smart with the data we have. And this idea, put in an example with the state of Merida in the Yucatan, the idea of spatial heterogeneity could be very clearly outlined. For instance, Merida has about 80% of the cases of the Yucatan state, which is quite large, concentrate in Merida. So this is already heterogeneity. One city, 80% of cases. But now if we go within Merida, 50% of the cases only occur in 30% of the area, which is marked in red. So in a way, if we have to be efficient, those areas, if we can cover them with highly effective control, might trigger all the way to the state, right? So because 50% of the cases actually for the state that are in Merida would be concentrated there. So this basic idea was in a way taken and really adapted and pushed forward by the Pan American Health Organization. And there's a technical document that was developed by PAHO in 3 languages, including English, where basically this idea of risk stratification was not only introduced, but presented in a lot of detail. And what I'm going to do now in the next few slides is just present you this approach of risk stratification, right? And the idea is, before I go that, this was a document produced by a large number of scientists and also vector control individuals, heads of control programs. So this is a document that is really bringing balance on pragmatism. So how can we use the information we have to try to inform some approaches for doing surveillance and control, right? So the idea for this document and the framework is that we have 2 levels of stratification. We can do stratification at the city level, as I showed you, Merida accumulating 80% of the cases. That would be one. So for this approach, we can look at cities as different scenarios, right? So we can look at no transmission, low transmission, intermediate transmission, high transmission, and episodic transmission like yellow fever. And that's something that would allow countries to basically rank each one of the urban areas within this types of scenarios. So that's something that many countries do. But what I'm going to focus primarily is in the second approach, which is once we identify these areas of high transmission, how can we go using data to try to basically identify hotspots of transmission, that 30% that I showed you before, right? And again, as a scientist and somebody who does a lot of statistics, it's easy to get people back down with complexity and equations. But one of the approaches that we followed here is to strike a balance between analytical complexity and basically robustness of the results. So in this case, we can do this stratification by just mapping cases, and many of you might be doing that. Or you can do this stratification by creating these super complicated individual-based models that have all these equations and parameters. Our approach is basically to strike the middle line where we find a statistical method that allows to conduct with relatively easy understanding of statistics, a very robust analysis. And that's what I'm going to show you in the next slides with an example. But this method was developed exactly to detect hotspots of events. In this case, we're interested in hotspots of transmission. So what requirements these analyses might have, and this is all published in an article that several of the members of the team I work with have co-authored. The idea is for many big urban environments, we tend to have distribution of cases at the, for instance, city block level or even address level. The idea is that those cases could be what we call geocoded to a census tract or census unit that might be applicable for the city. In this case, for Merida, this is what we call a census tract. It has about between 10 by 10 or 5 by 5 city blocks, which turns this area also an operational unit for control. It's easy to do interventions within a 10 by 10 city block compared to an entire neighborhood. So once we have this data aggregated, the other thing that would be required is at least 5 years of data. And that's mainly to capture interannual variability. We all know dengue and Zika and chikungunya do not happen every year. So if we have multiple years, we can actually make better sense of where what we want to measure, which is a spatial anomaly of your data. So where those areas of high risk might be occurring. So in Merida, what we did is we had geocoded cases from 2008, 2015, 40,000 of those. And basically we conducted all these analyses with free and open access software to look at basically where these cases occurred over time. So the redder in this map, the more cases we had. The idea is, can we identify some of these areas that might be the ones harboring most of the transmission? So we did that. We applied this analysis on every year. Now the red indicates hotspots for a given year. And now you see the value of having multiple years because this figure here shows the additive. So how many years one of these census blocks was a hotspot, right? So we have a core high area. No matter which year, this area always have cases. Others in the periphery vary a bit more, but the idea is this is the 30% where more than half of the cases were reported. Now, this was a statistical analysis based on passive surveillance data. So if we actually look at the data now from independent to do some validation, we were fortunate to, at the same time of running that analysis, having a longitudinal cohort of children and their families. So we had data from serological surveys done on children. So what we did is comparing what happens in kids living outside compared to inside the hotspot area. And what we found is that infection in children living inside the hotspot area was 1.7 times higher than outside. So keeping all the other factors equals, there's almost 2 times higher risk of being infected by dengue if you're living in this area. So that's really strong validation of our findings. The other thing we did was looking at this now across different cities, because again, we worked in Merida, but the idea, and this was in collaboration with the SENA-PRESE, the Center for Disease Control in Mexico, we were able to gather information from 9 other cities that accumulate a significant number of dengue cases in the country, no matter which year. They actually are hotspots in themselves. And what we found is that for all these cities, we could find areas that systematically had accumulated high number of hotspot areas, right? So this very dark red means in 8 years, all the years, that census block was a hotspot. So in a way, what this allows us to do is provide validation that what we found in Merida now extrapolates to many other urban environments with different population environmental conditions, right? So in a way, this approach of analytical approach is very robust, but also has to be thought within a chain of events. And I like this figure, which is in that manual that Pajo developed, because it's really about how do we incorporate risk mapping within an integrated vector management plan, right? And the idea is that we have, a scenario, we identify our city to be high risk. Then we collected some of the data. I told you 5 years at least, and geocoded. Then we did the analysis, right? And we stratified. So we can actually do interventions now, surveillance and control that might be different in the hotspot area versus non-hotspot areas. We can also do vector control differently in those areas. Preventive control, TIRS, might be more applicable in these high risk areas, for instance, because it's a place that no matter which year you might have some dengue accumulation, and as well as monitoring. And this is really important because it means that after we do these interventions, we might be able to collect new data and rerun the analysis and see how these hotspots might be shifting due to new epidemiological conditions happening, right? So just to finish this part, in a way, what I'm showing you here is really one component of what I think Pan American Health Organization, and in part driven by this new plan, the Action for Vector Control, that was signed by all member countries. PAHO is really driving this change in rewriting history, moving into new tools, data, different approaches for insecticide control. And I feel that this idea of risk mapping is at the core of how we can structure programs in a more efficient way. So some take-home messages from this part, is that risk stratification as is really a key process for at least at a minimum increasing efficiency. We can focus our efforts better if we do things preventively versus reactively, and also we can program our approaches differently if we know how different areas might be behaving in terms of risk. The other really important approach is that what I'm showing you is something that is dynamic. So as it's integrated in programs, it could actually lead to reevaluations every few years to see if shifts in the location of hotspots might be occurring due to different conditions. But at the end, one of the final questions is, can we transfer this knowledge to other countries? Can this be transferable beyond this scientific exercise and collaboration with Senapresa in Mexico? And we did that. So we, in partnership with the Pan American Health Organization, led by them, there was a training workshop done in Costa Rica, where many member countries, both from South America, Central America, and the Caribbean participated. And the idea of this workshop was really transfer this approach of spatial analysis and mapping to countries, so they could actually look at those and run the same analysis with their data, right? And the workshop was quite successful. We had a representation for over 14 countries, and I can talk extensively, but you can see now some of the examples done by the participants with their own data. Trinidad, Honduras, Guatemala. So all of these show exercises done in a 3-day workshop with data that the countries provided. So I think there's a lot of excitement about the potential for this approach. And also there is probably a key message is that there is a tremendous value in the data that's being collected, especially in high risk urban environments, to actually make some changes in how surveillance and control might be done. And with that, I would like to first and foremost acknowledge my collaborators and members of my group. This is really, I'm the voice, but there's an extensive number of people who have participated and constantly participate on this effort. Particularly, I would mention Pablo Manrique Zaide from the Autonomous University of Yucatan, who's basically the key person and developer in a lot of what we're actually doing in Merida and then testing and scaling up in other urban environments. And with that, I would like to take questions, if any, and thank you very much.
Thank you very much, Dr. Vasquez Prokopek, for that very interesting presentation and bringing home to us the fact that we need to actually do things a bit differently from how we've been doing before if we expect to be effective in controlling Aedes aegypti and in actually reducing numbers of cases of these vector-borne diseases. So I'm going to see if there are any questions coming from our viewers. Please feel free to send in your questions. While we wait for some questions to come in, I would like to elaborate a bit on the use of some of these devices for mapping, for doing the risk mapping, because we have been working with some countries in doing training on use of the GIS tool, and looking at trying to actually identify hotspots. And I think the examples that you gave and the assistance some countries had to start working on actual mapping and the geocoding of data to be able to visualize where the hotspots are is very, very important. So we've been working with countries to do that. And also you mentioned integrating the data from insecticide resistance tests. And that's another area that support is being given to help countries to strengthen their vector control programs. A question I would ask then is, I know you gave a few examples of where it has been done, but in countries, especially the Caribbean islands, where the numbers are not so high in some given years, if there's not many cases, you might have 2 cases reported or 3 reported. How would that help us in terms of predictions, for example? If we can say that the urban areas are the areas where we would tend to have cases happening if they happen based on what we know. But if we have very low numbers of cases being reported each year, how do you suggest we work in terms of trying to do our prevention then? That's the question.
Yeah, so I think, first of all, the answer is always depends, right? So depending on the context of the environment we're talking about, if this is an area prone to invasions, sporadic invasions of arboviruses, having these hotspots might allow countries to do more targeted surveillance of vectors. I'll give you an example. In the city of Merida, the Ministry of Health is using these maps to target the location for collecting mosquitoes. The period where, they know when seasonally dengue cases may start. So they actually collect mosquitoes and do pools of mosquitoes and test for virus. And I'll give you a clear example that basically dengue 3 was detected in a pool of mosquitoes in Merida, which prompted the Ministry of Health to very aggressively do vector control. And the main reason is because dengue 3 was never found in Merida. So the assumption was everyone was going to be susceptible to dengue 3. And that action by the Ministry of Health actually basically contained transmission. There was no outbreak of dengue 3 in that situation. So the idea is they cannot do that surveillance throughout a large urban environment, but they can target those locations. And our study in Merida and also in the other Mexican cities found that the hotspots for dengue were the areas where the first 10 cases for Zika and chikungunya were also reported. So the hypothesis is that these might be also the places where dengue, chikungunya, and Zika outbreaks might also be initiated. So then it makes sense to use them as sentinels for some targeted detection, either just placing ovi traps to capture better the entomology of resources. If resources allow, maybe do some of these viral detection in mosquitoes. But the idea is, in a way, the map allows you to visualize better what can you do if you know that these areas might be the ones that start the fire in a way.
Yes, yes. In terms of the surveillance, most islands are still focused on larval surveys. So the house-to-house inspections with, checking every container to see if it's positive for Aedes aegypti, and then producing those house indices, Bretto indices, and so on. But we know that the translation of that data to having an outbreak or having cases is not, the link is not as direct as if we were collecting or checking for adult mosquitoes. But one of the issues has to do with the how labor intensive that process is. Is there any comment that you would make where that is concerned?
Yeah, well, definitely, evidence from multiple countries and research studies show that, if we weight the strength of different entomological surveillance methods, looking at larval methods is weaker than looking at pupal surveys, and looking at pupal surveys is, weaker in terms of ability to give a signal of risk compared to adult female mosquitoes indoors, for instance, right? And the same for eggs. Eggs, there are multiple examples that show that in some cases, maybe ovitrap data shows some association, but when you actually go into the final level, at the level where the traps are set, the information is, the support for their role is quite weak. So then, one enters into a dichotomy. Do we use a method that you can scale, is really affordable, like ovitraps, but might not be giving you accurate data for what people are intended to use it, which is responding to risk, or we actually move to a method with like adult collections, which you can use traps, or you can use active collections like adult aspiration with some of these vacuum aspirators. So there are pros and cons, but I would say that the closer you can get to adult indices, the more reliable your information is, because the adult indices really can give you an idea of not only what's happening in the mosquito population, but also what's the impact of any intervention. And for most of our countries, transmission is primarily indoors. So then anything that has some impact in outdoor mosquitoes with very low sensitivity, we do not know the impact that might have indoors.
There is a question here. What is the main gain in using IRS in specific places versus the traditional method?
Okay, well, I assume traditional method might be reactive, track mounted ULV, let's say, unless there's some other explanation. But the gain is in a way that any approach that involves a residual effect, in this case insecticide, could be deployed before the transmission season. So in most urban environments, we have a seasonal trend during the year in terms of when dengue or other arboviruses are transmitted. So TIRS, the targeted indoor residual spraying, and we've done some interesting analysis to do that, to show that, could be done about, if you look at the seasonality of dengue, it could be started about 3 months, 4 months before the transmission peak, because this method would be accumulating its effect over 3 or 7 months, depending on the chemical that we're using. So the other advantage is that, because there's strong development of residual formulations for malaria, those formulations, which are all approved by the WHO, could also be implemented in countries that have them approved, of course, but also that have resistance to pyrethroids that are common in basically throughout our region. So that allows some not only vector management, but also resistance management, because the residual insecticide has less of an effect in terms of sublethal doses that you might find when you apply the ULV. So then the benefits or some of the gains would be related to efficiency. You can use your personnel when they're not responding to cases. And that allows you to cover more geographic area. The other one is that you have a long-lasting application. In Merida, for instance, we're talking about TIRS takes about, on average, 11 minutes per house. And we are using an insecticide that gives between 6 and 7 months protection. that is pyrimidine methyl. So we're talking about, if I go to your house and I say a 12-minute application would protect your house for 6 months, well, that actually becomes more feasible if you can deploy it, not when you have an outbreak. And the other one I think is that this is an approach that will be applicable for this idea of risk stratification, where you actually do not apply it randomly. You have to be very focalized.
Thank you very much. I think I'll ask also in terms of follow-up for the targeted indoor residual spraying. In your work, have you seen any, and this question comes from a cultural perspective. So there are countries persons in countries where, for example, malaria is being transmitted, who are accustomed to having their insides of their home sprayed. In the Caribbean, especially English-speaking Caribbean, we do not have active malaria transmission. So persons are not familiar with or accustomed to sprays, insecticides being applied to their indoor of their homes. Have you seen any cultural resistance in any of your work where persons are going to apply indoor residual spraying for Aedes aegypti? Because that's one of the barriers I think we would have to overcome in our region to deal with that.
Well, I would say that, it's all about what the barriers to indoor residual spraying are. And there's some evidence that in other cities and for other contexts that some of the main barriers were how labor intensive classic IRS was. People cannot spend, hours preparing their house. In our experience in Merida, where we sprayed over, more than 1,500 houses, in different trials that we've done, over 90% of people accept to have the intervention. And if they do not accept the first time, when they see how it's done, they end up agreeing. And in a way, this is like a pest control. It controls the roaches and other bugs in the house. So in urban areas, some people might actually be aware of that. They actually spend money buying insecticides to their houses, aerosolized insecticides, for instance. So I think, sometimes it's not about generalizable barriers. It's about, there might be some specific barriers that are cultural, and those could be addressed by actually knowing what people's concerns are. But we also found that through understanding what the barriers are, and also in our case, minimizing the time it takes to spray a house. The biggest barrier is asking for more than 20 minutes, half an hour of somebody's time to do the spraying. And right now, the methods we do could actually cover less than that. So.
Okay, thank you very much. I'm not seeing any more questions, but if persons do have questions after thinking about the presentation and reviewing the document which you have access to, I would suggest that you could still send them in to us, and we would answer and follow up with how we can provide assistance to you. So just to wrap up before we go, if there are no additional questions, Dr. Vasquez Procopec presented some interesting information to us, looking at the fact that there are quite a number of persons who are asymptomatic for dengue, who could be contributing to the outbreaks that happen. The graphic of persons, the movement of persons was really startling to see, when we're doing our control, where we go to visit someone's home who is suspected of having dengue, and to see that it really is not that the person may have contracted it at their home, but elsewhere, and just to see how much movement we do or we make as human beings, which also contributes to the problem. And I think though that having us focus on some new approaches or new methods to how we do things, for us to be more targeted in what we do, so it becomes more effective, whether it is that we're looking to prevent or react to something, but just to point out that having focused approach to what we do, knowing where our hotspots are and zoning in, then we can target our interventions to have more effective, or measures being more effective and efficacious. So that being said, I would like to thank Dr. Vasquez Procopec again, and to thank you, our viewers, for joining in. And we look forward to continued engagement with you. So I say to you to be safe, especially during this COVID season. Thank you very much.